Andrology Forum. It is my honor to introduce a great pioneer and global leader in the field of andrology, Dr. Ashok Agarwal, the founder and director of Global Andrology Forum.
Thank you very much, Dr. Arman. Thank you for introducing us, Gunaydin Arkadasin. So, I wanted to practice my Turkish, which means good morning, friends. So I'm very pleased, along with my distinguished colleagues here, to participate in the program for the Andrology Working Group of the Society for Urological Surgery in Turkey. And we have a very exciting program planned for the next 2 hours. So let me begin by sharing my presentation, which is a brief introduction. So let me just share the screen. Give me 1 second. So again, I think I will introduce my colleagues in the coming slides, but briefly, I wanted to explain what is Global Andrology Forum. This is a brief biography of myself. The Global Andrology Forum was started or was created.
No, the slides are not visible.
Nothing is showing up?
No.
No.
Oh, okay. I think maybe I didn't share it correctly. Just a second. I will share now.
Yeah, now we can see.
Yes.
So let me make it bigger. Okay, sorry about that. So there's an introduction about the Global Andrology Forum. This is just about my biography. The Global Andrology Forum was created about 3 years ago as an international online group focused on andrological research. In the last 3 years, as of now, we have about 830 members from 95 countries, and these include predominantly andrologists, urologists, and uroandrologists. Our mission is to conduct the highest quality research, and mainly we are focused on systematic review and meta-analysis, but in recent days we are also using the evidence that we have created in various aspects of male infertility and male sexual dysfunction to develop clinical guidelines which are globally based. And we are going to have those discussed during our in the presentations that are planned for today. So our vision is to create a global collaboration of clinicians and researchers to promote scientific excellence in the field of andrology. These are the members of our management team. Some of them are from Turkey, but we have from all over the world, as you can see. This is a breakdown of our membership as of a few weeks ago, and you can see they come from all different parts of the world. And our membership is spread out from all different parts of all different continents. As you can see here, the largest number are from Asia, and but we do have a spread out in other parts of the world. It is from Asia because Asia has the largest number of countries as well. Turkey comes from there. The annual growth of our members can be seen here, and you can see we have really been very lucky that many members have, many people have, are very interested in the work that we are doing. And this is a breakdown of our members according to their self-described profession. A majority of them are andrologists and urologists, but we do have a large number of researchers, which are the backbone of our work, and endocrinologists as well as other clinicians. Here, I think you will find most important thing is that what are we doing with our membership? And I think this is the most important slide. This may not be completely accurate in the sense that the numbers are much more than what we could capture in this slide, which was done in a hurried manner. But in the last 3 years, we have approximately 100 publications in peer-reviewed journal, which is astonishing for an organization or for any, even for a country. And the number of books that we have published are 3. Several more books are in the final steps of being completed. At least 4 more books are there. Then special issues of journal and citation, webinars, book chapters, in-person meetings, global survey. So this is not a complete but a snapshot of our activities related to andrology. So everything that we are talking about is in andrology, whether it is in male infertility or in the last 1 year, also we have branched out in male sexual dysfunction. What do the members do? They have a lot of choices. They can participate in a number of activities, research activities, educational activities, training activities. They can serve as speakers. So there are dozens and dozens of options for members to participate according to their interest. So this is essentially a snapshot of our members here. You can become a member by going to www.globalandrologyforum.com and apply online. So application is online, and you can find it by searching it on the search engine. Let's go to the actual program for today, which is really exciting. A program that we have planned. Our first presentation will be by Dr. Eduardo Pescatori, and I will come to it in the subsequent slide. Then he will be followed by Dr. Rupin Shah, then Dr. Giovanni Colpi, and lastly by Manav Al-Hashimi. Dr. Eduardo Pescatori from Italy is a urologist and andrologist, a distinguished person who has done a great deal of both clinical and research work in andrology, as you can see. And Eduardo will be talking on the newest clinical guidelines on the role of sperm DNA fragmentation. And this study has, I believe, has just come out. So these are his learning objectives. He will be providing his guidance on the role of sperm DNA fragmentation as to the GAF clinical guideline, why they are so different than others like EUA or AUA or ASRM. SDF, what is it? Why should we care about it? What is the path to 2025 clinical guideline? How did we come out with this? What was the procedure? What is the methodology involved? He will then present the guidelines, which includes 24 statements and recommendation. The next speaker is Dr. Rupin Shah, who is a senior consultant, andrologist and urologist, a senior member of our GAF core management team, the advisory group. And he has a distinguished career in the field of andrology. As you can see, he is involved in large number of committees and guidelines in the area of andrology. Dr. Rupin Shah is going to talk about the management of varicocele. He will provide practical advice on the management of varicocele, discussing diagnosis, identifying the right candidate for repair, choosing the right surgical technique, and monitoring and complications. So this will be his talk, which will be followed by our third speaker, Giovanni Colpi from Switzerland, originally from Italy. He is the head of Andrology Unit and Scientific Director of Andrology in Lugano, Switzerland. He is a very well-known andrologist, surgical andrologist, and an academician of the European Academy of Andrology. Giovanni is going to talk about the management of non-obstructive azoospermia. He will give his advice, and these are the topics that he will cover, as you can see in the learning objective. There are 49 statements and recommendations which are part of Global Andrology Forum guidelines. So this will be a very interesting presentation. Our last speaker is Dr. Manaf Al-Hashimi, who is from Abu Dhabi, and he is a consultant in urology and andrology and head of the Department of Urology. And you can read, he occupies many different positions. Dr. Hashimi is going to be talking on the role of antioxidant in the treatment of male infertility and will provide advice to discuss the current clinical practice on the use of antioxidant and evaluate the evidence-based role of antioxidant in management and how to apply the guidelines developed by Global Andrology Forum on the use of antioxidants in clinical practice. This will be followed by the discussion, question and answer, and at the end, there will be a take-home message where Dr. Rupin Shah is going to provide a take-home message from all of these talks. So thank you very much, and I hope you will enjoy today's excellent program, which has been put together by our very best speaker in the Global Andrology Forum. Thank you very much.
Thank you, Dr. Agarwal. And our first speaker is Dr. Eduardo Pescatori. Now, floor is yours.
Okay. Thank you, everyone. It's really a pleasure to be today with you. It's just sorrowful to be far away because the little experience that I have from Turkey so far has been really exciting and great. So it suffers to be here and to know that you are there. My talk today, as has been already anticipated by Professor Agarwal, concerns the guidelines, the clinical guidelines of the Global Andrology Forum regarding the role of sperm DNA fragmentation. Okay. I'm trying to see how, I don't know how to advance. Okay, I have it. These are the areas that I will cover. Why the clinical? I will spend some of the talk covering a general issue of Global Andrology Forum guidelines and to see why they are different compared to other guidelines. This will cover not only sperm DNA fragmentation, but in general Global Andrology Forum guidelines. Then I will move to the specifics of sperm DNA fragmentation. What is it? Why is it important for us? And then how the Global Andrology Forum arrived to draft these clinical guidelines to enter in the specifics of the 24 statements and recommendations of the guidelines. So, first of all, why GAF clinical guidelines are different? We know that scientific societies' guidelines are widely adopted to try to overcome discrepancies in the management approaches and variations in standard care across different countries. Anyhow, there is a problem that in the area of male infertility, sometimes we have some inconclusive diagnostic and treatment pathways due to limited clinical trial evidence. And this is when Global Andrology Forum comes into place in trying to overcome these limitations. In fact, GAF guidelines differ from other guidelines because they are based not only through a review of available literature, but also from evidence from systematic reviews conducted by GAF itself, and from global clinical practice patterns that are identified to global surveys. This is something typical of GAF, and I would like to spend a word on this. It's a real-world evidence of experience of all clinicians around the world, and this is especially valuable when the literature is insufficient, and this allows a recommendation to be shaped by expert consensus. In fact, the recommendations that then are elaborated by GAF are approved by a larger number of senior experts from across the world through a specific and defined scientific process that is the Delphi process. In this slide, I would like to compare the guidelines put out in the area of infertility by different societies and what the GAF does. If we consider what exists in terms of the key presentations from the major associations, scientific associations, we see the combined guidelines of AUA, American Society for Reproductive Medicine, where their panel members are 15. And please remember that we're talking about AUASM, that is United States only. Then we have the European Academy of Andrology, again, we're talking about mainly Europe, that is 8 panel members. The Italian Society of Sexual Medicine, it's 13 panel members. European Association of Urology, 21 panel members. European Society for Human Reproduction and Embryology, 13 panel members. The combined guidelines of the German Society of Gynecology and Obstetrics, the Austrian Society of Gynecology and Obstetrics, and the Swiss Society of Gynecology and Obstetrics, total number of 28. If we sum up all these members, we come up with a total number of 19 experts. Let's now see what the GAF does. And as an example, I will talk as an example the guidelines concerning my talk, that is sperm DNA fragmentation. First of all, let's consider the global survey that has been put forward on indication for testing and treatment for sperm DNA fragmentation. This global survey has been the result of the inputs provided by 436 experts across 15 countries across the world. The expert recommendations have been then evaluated to reach a consensus through the methodology I mentioned before, that is the Delphi method. But GAF has not been satisfied yet, because it was important also to produce a score in a strong or weak recommendation, and to elaborate all the previous, that is surveys, reviews, meta-analysis, and also other society guidelines, and to elaborate them, to come out with the final 24 statements that we will go through. And this is the work done by 52 GAF experts. So the total of people involved has been 551 experts across the world. Different countries, different methodologies to try to find out a common path. So GAF guidelines in general, they aim to fill the gaps left by existing recommendations by integrating scientific evidence, real-world clinical experience in order to provide andrologists with clear and actionable guidance, something that wants to be very practical. Let's now move to the core of my presentation, that is sperm DNA fragmentation and the GAF guidelines. First of all, sperm DNA fragmentation. What is it? Just one slide to remind you that sperm DNA fragmentation is a marker of damaged chromatin in spermatozoa that include single, double strands breaks, base deletions or modifications, and protamine deficiency. Why do we care about it? We care because elevated sperm DNA fragmentation is associated with failure of natural pregnancy. Not only, but when we get to assisted reproduction, it has been shown that elevated sperm DNA fragmentation correlates also with failed intrauterine insemination. And also recurrent idiopathic pregnancy losses have been linked to sperm DNA fragmentations. There are many other things that are involved with sperm DNA fragmentations, but these are the three key messages that I would like to provide you. Now, let's see how Global Andrology Forum got the path that followed to get to the present guidelines. It has been a long and winding road to reach these final guidelines that I will present. In the years, there have been different contributions of all the key people of the Global Andrology Forum concerning a clinical assessment of clinical practice guidelines, concern informations for the reproductive physicians, concerning the usefulness of DNA fragmentation for assessing male fertility and assisted reproduction technology outcomes. But I would like to focus especially on the next three papers, because this one is a key global survey for what concerns technical aspects on the realization, the testing, the actual tests of sperm DNA fragmentation. And you see that here, considering the people working all over the world, this is what we got. We got for the first time a clear representation of how things work across the world, with the highest prevalence of the tunnel test, followed by SCD and SCSA tests, last the COMET test. Finally, we have a really clear representation of what is going on. Next, what are the indications? Again, this is a global survey on the indication all over the world for the use of the test for sperm DNA fragmentation. And also here, we got for the first time a clear overview of what is done in terms of indications, and you see that here you find unexplained male infertility, idiopathic male infertility, recurrent pregnancy loss, risk factors, sperm cryopreservation, and the utility of the indication of sperm DNA for sperm cryopreservation. When assisted conception fails, the presence of clinical varicocele. What I would like to, besides this very nice pictorial, to emphasize is that it clearly emerged that an indication that the need for sperm DNA fragmentation goes well beyond the simple semen analysis. This is to say that we cannot just think that because a simple semen analysis is fine, we don't need further investigations. Alteration of sperm DNA fragmentation may well be present also in presence of normal sperm analysis. And this is a message that we should carry through also from our fellow colleagues, gynecologists. The other key global survey concerned the management across the world of elevated sperm DNA fragmentation. And what we collected is, in fact, all the strategies that we have now available, and in fact that are enforced by all the friends that got back to us during the survey for impact on elevated sperm DNA fragmentation, lifestyle modifications, weight loss, reduce abstinence, because we know that there is a high abstinence, a low frequency of intercourse, sperm DNA fragmentation goes up. We should treat genital infections. Antioxidant supplementation has a role. Varicocele definitely has a role. Hormonal therapy, if needed, because of hormonal status, has a role. ICSI, of course, it's important. If sperm selection techniques are important, if sperm DNA fragmentation is high, and there is also a place to obtain sperm directly from the testes if fragmentation is high, because the path through the epididymis may be one of the aspects that increases sperm DNA fragmentation. Having said it all, now all the previous background has been put together to draft the present guideline. And this is actually the paper that has been just submitted, and what we have here is really a word preview of this paper that maybe, from what I understood from Ashok, has already been published, but must have been a matter of a few days, because from what I knew it was still to be ahead of print. And this is basically a summary slide. These guidelines are the distillate of a lot of things, of GAF systematic reviews, GAF global surveys, those that I just mentioned to you, and the scientific society guidelines. All together went through a grading process to again, through a structured path, scientifically sound, to define strong and weak recommendations, and the final outcome are 24 statements and recommendations that I'm going now to go through. You see that in the paper, you see that statements are graded in strong or weak. And there are different areas. The first area is unexplained and idiopathic male infertility, and the strong recommendation is that all men with unexplained idiopathic infertility should undergo sperm DNA fragmentation testing. Recurrent pregnancy loss, again a strong recommendation. Should be SDF should be considered in the workup of any recurrent pregnancy loss, because we know that it's increased in the population of affected by recurrent pregnancy loss. Clinical varicocele should be considered in the workup of a clinical varicocele, not in subclinical varicocele. I would like to give you a practical example. If we have a varicocele and a normal sperm analysis, some of us would stop there, but probably it's not appropriate. If in these people we do sperm DNA fragmentation, we could isolate a group of people that have varicocele, normal sperm analysis, but high sperm DNA fragmentations. And these people may clearly benefit from treatment of their varicocele. And this is what has been said also in the next statement. Assisted reproduction technologies. You see different statements from 5 to 9. They overall say that the sperm DNA fragmentation should be considered to be taken in account when we get to assisted reproductive technologies. It's not, does not make any sense anymore to see that we need just one sperm to do sperm DNA, to do a assisted conception. We need to know what kind of sperm we are dealing with, and we need to try to treat as best conditions in which we find elevated sperm DNA fragmentation, because this may in fact impact of the outcomes of assisted reproductive technologies. The methods used to sperm DNA fragmentation, it's clear, and this just confirms the indications of the WHO on what are the tests and the cutoff. And we have also a weak recommendation that probably is not necessary to order a second confirmation test if we find an elevated first outcome of the test. Treatment of sperm DNA fragmentation when it is elevated. And here we have strong recommendations to address risk factors like smoking, aging, obesity, chemical exposure, alcohol, and infections. Out of these, lifestyle modifications, in particular, to impact on ejaculatory frequency before attempting conception, and this can be valid for also what we already mentioned, recurrent pregnancy loss, to impact on these lifestyle modifications. Antioxidants may have an impact in addressing elevated sperm DNA fragmentations and varicocele repair. But if there's been also a very, very important revision paper by Rossella Cannarella of the Global Andrology Forum that has been put forward last year, that in fact varicocele repair may significantly reduce sperm DNA fragmentations in patients with elevated levels, and should be offered to these patients. Of course, we know this if we investigate the patients, so it's important to offer sperm DNA fragmentations when we have patients with varicocele. The last two statements, recommendations: sperm selection techniques for ART can be used in cases with elevated sperm DNA fragmentations and selecting of ART failure and setting of ART failure. Strong recommendation. And a strong recommendation for the use of testicular sperm, that if it's true that they are not recommended for routine cases, they may be considered in those with elevated sperm DNA fragmentation after addressing protection under onychosis and in the setting of heart failure. So, in conclusion, the current GAF guidelines will guide clinicians and researchers in implementing clear management strategies for infertile males who need the sperm DNA fragmentation testing or have elevated STF. They allow to integrate sperm DNA fragmentation testing into male infertility management with a tailored individual approach. And they will also help answer practical questions for which rigorous evidence may not yet be available right now. Thank you very much for your attention.
Thank you, Dr. Pescatori. Our next speaker is Dr. Rupin Shah. Dr. Shah.
Good afternoon to everyone, and I'd like to thank Dr. Pescatori for explaining how the GAF guidelines were created, why they were created, because as we shall see, particularly when it comes to varicocele, that it really makes a difference when we look at the existing guidelines and what GAF is going to recommend. And the reason for this is that varicocele is one of the most researched topics, but despite that, there is a huge amount of confusion because the subject itself is confusing. Many fertile men will have varicoceles and will have no impact of the varicocele. Many subfertile men who have varicocele will achieve fatherhood even if the varicocele is not corrected. And many of these infertile men will remain infertile even if the varicocele is corrected. But there are also some men who have dramatic improvement after varicocele repair. So, of course, it means that not everyone needs surgery. And as good clinicians, we need to identify who are the patients who would benefit. How do we diagnose them? How do we stratify them? What is the prognosis we give them? And which conditions are most likely to improve? So all these questions need to be answered practically, because in every meeting we find that these questions are raised again and again by the clinicians. So if you look at the two main guidelines, the AUA and the EUA, we find that actually there are huge lacunae. Take the most important recommendation from AUA, that varicocele surgery is indicated in infertile men with abnormal semen parameters. This is a statement that lacks qualification and actually can be misleading, because abnormal semen parameter could be 0% motility. So a man with 0% motility and a varicocele is not going to benefit from varicocele repair because the cause of 0% motility is different. Or if he has a good count and total necrosospermia, that probably has nothing to do with the varicocele. And there are many such lacunae in the guidelines of both the AUA and the EUA. Also, there is conflict. For example, if you take this important topic of varicocele in non-obstructive azoospermia, the AUA guideline says that there is lack of evidence supporting it and generally recommends against it, while the EUA guideline says that there may be appearance of sperm, fertility may improve, and it should be corrected. So because of these lacunae and this conflict, we decided to spend a lot of energy in the Global Andrology Forum on evaluating varicocele. So we had a systematic review meta-analysis of randomized control studies. We had another SRMA on observational studies where the patients before and after varicocele repair data was analyzed. We had a systematic review on sperm DNA fragmentation, which Dr. Eduardo just referred to. We have another systematic review on changes in hormone profiles after varicocele repair. And we had a very important global survey on how people diagnose and treat varicoceles, where we had a large number, 574 people from around the globe responding. So the purpose of today's talk, the next 15-20 minutes, is to give practical advice, focusing on those areas which are controversial. A comprehensive review of all the guidelines would take more than an hour, so I'm not going to cover everything, but some of the guidelines that we have evolved where we feel that the clinician might be confused and might benefit from clarity. So these recommendations, expert recommendations, which we will provide, will be derived from the survey which we have conducted, which looks at real-world practices. It will look at the best literature. It will look at the systematic reviews that we have conducted, as well as the existing literature and the recommendations from other societies. And all these are then synthesized, and a recommendation is made that represents the opinion of a large number of very senior experts. So let's start with the first question that often people have. Should we be doing an ultrasound for everyone to look for varicocele? And that's what I see in practice every day, because I see secondary and tertiary referrals, and most urologists, when encountering male infertility, will refer the patient for an ultrasound examination, though the AUA guidelines, the ASRM guidelines, the EUA guidelines state that the routine use of ultrasound to diagnose a varicocele is not indicated, And that links with their subsequent recommendation that subclinical varicocele should not be treated. So if you don't want to treat a subclinical varicocele, there's no point in doing an ultrasound examination if clinically there's no varicocele. However, in the global survey, we found that more than 2/3, 70% of the responders used ultrasound and examination together. And as we looked into the detailed responses and the expert opinion, the final recommendation was that if someone is physically completely normal, after a good examination, you do not need to do an ultrasound to look for a varicocele. However, if the examination was difficult or equivocal, the cord is thickened, but one is not sure if there's a varicocele, ultrasound is indicated. Ultrasound is indicated to quantify the amount of reflux, and Professor Kolpe will be speaking next, in fact, has a couple of very important papers showing how high reflux varicoceles are more likely to be benefited from surgery. And finally, if there's a varicocele on one side, then you'd need ultrasound to assess it on the other side. So the final conclusion is that do an ultrasound with an examination in the various situations that we recommended, but not for everyone. Then the most important question, as we said, not everybody needs varicocele surgery. So does varicocele surgery really help, and if so, to what extent? So there have been many studies like this one, which is widely quoted, where a comparative group of people operated and observed showed that when the varicocele was operated, there was a much higher pregnancy rate. However, there have been other studies like this one, also very widely quoted, in which whether the varicocele was corrected or not corrected, the pregnancy rates were the same. And for urologists, this is important to remember, because a lot of uroandrologists think that varicocele present, we have to operate. Not true. In fact, in the first 3 Cochrane reviews, the conclusion was that varicocele surgery does not help. It was only in the 4th review in 2012 and the most recent review in 2021 that the final conclusion came that, okay, varicocele surgery will improve pregnancy rates. However, there's still not enough data to say whether live birth rate really improves. And of course, the Cochrane review felt that the quality of evidence was not very good. However, the meta-analysis that we conducted, the 2 which I quoted earlier, showed very clearly that count, motility, morphology altogether improve in a significant proportion of patients after varicocele surgery. So the expert opinion is that yes, varicocele surgery can definitely help couples. It'll help more than 50% of couples, but not all. And therefore, if it's a young couple with a short trying time, it is justified not to rush into surgery, give them a chance to conceive without surgery, and many of them will, to their delight and to our surprise. And they may be offered medical therapy, which we will talk about. And if they have not benefited over a period of observation, or if the couple is older, or if there's already been trying for a long time, then we could recommend varicocele surgery right away. On the other hand, if we are looking at specific situations, good count, but severe isolated asthenospermia, good count, severe teratospermia, there the indications are a little more controversial. The AUA, EUA guidelines have no specific comment on this. In the global survey, we found that the majority of respondents would actually still consider varicocele surgery for isolated asthenospermia. The expert opinion was you need to distinguish between grades of asthenospermia. Moderate asthenospermia, perhaps varicocele surgery will help improve it and normalize it. But severe asthenospermia, 0% motility, 5-10% motility, more likely has a different cause, sometimes genetic, sometimes immunological. And in those cases, varicocele surgery may not help. So depending on the clinical picture, in some cases, varicocele surgery may be indicated for isolated asthenospermia. When it comes to teratozospermia, again, AUA, EUA, no recommendation, but surprisingly, a large number of respondents, 40% routinely and 30% sometimes, would still consider surgery. However, here the expert opinion was not in agreement with the global practice, and the general opinion of the experts was there's no evidence really to support varicocele repair in isolated teratozospermia. So very good count, very good motility, but 2% teratozospermia. Probably the cause is different and the varicocele has nothing to do with it, and correcting the varicocele will not help. We already had a wonderful talk on varicocele sperm DNA fragmentation. So in the survey, and this is a specific group, men with normal sperm counts, but elevated sperm DNA fragmentation and a varicocele, would you operate? So again, dispute. The EUA guideline is not in favor of surgery. The EUA guideline suggests that there is evidence favoring a role for surgery. In the survey, 1/3 of surgeons said that they would operate even with normal semen analysis. So the expert opinion was that be a little conservative, try the other measures that were listed in the previous talk. But if they fail to benefit, then elevated sperm DNA fragmentation, even in the presence of normal semen parameters, can be an indication for varicocele repair. And in the next section, we'll look at what is the expected benefit. So here was a study that we conducted, which showed that repairing a varicocele can reduce the sperm DNA fragmentation by 4 to 10, averaging 7%. So it's not a very dramatic reduction. If somebody has 80% fragmented sperm, the varicocele surgery may not make a clinically relevant difference. But in a large proportion of cases where the sperm DNA fragmentation is between 30 to 40%, the varicocele repair may bring it down to a level where the pregnancy rates will improve. So the expert opinion is that you can consider varicocele repair if the other measures have failed. And this links to the next scenario, which is a tricky one. So let me explain it clinically. So if you have a young couple or a middle-aged couple married 4 or 5 years, has moderately severe oligoasthenia, 5 million, 20% motility, and a large varicocele, but they've already decided that we want to do IVF because we waited 4 years and the count motility are low. Now the question arises that should they proceed for IVF right away, or should the varicocele first be corrected, wait for 6 months, and then let them go for IVF? Of course, if the IVF specialist is in charge, they're going to drag away the patient for IVF. But what is the evidence? So we have here a systematic review where Professor Agarwal was the last author. And there they found 4 randomized studies looking at ICSI outcome in patients with varicocele, one group who had surgery, one group who did not have surgery. 3 of these 4 papers found that if the varicocele was corrected before ICSI, the pregnancy rate and the live birth rate were higher. One of the 4 studies found that it didn't make a difference whether the varicocele was operated or not. Another meta-analysis looked at the role of varicocele surgery, both in oligoastheno and azoospermia, prior to ICSI. And once again, they found that, yes, the live birth rate will increase if the varicocele is corrected first. And the explanation is that this is connected to what we spoke about, that varicocele surgery will reduce sperm DNA fragmentation, improve sperm quality, and thereby improve the final outcome of ICSI, or even IVF for that matter. And the study also showed that there was a strong trend, but it didn't reach statistical significance, even in azoospermic men with higher birth rate, if the varicocele is corrected. In our global survey, what we found is that 2/3 of the respondents said that they would recommend correction of the varicocele before IVF ICSI. About 1 in 5, 18% said that they would recommend it conditionally if the patient had high sperm DNA fragmentation, then they would ask the couple to wait, correct the varicocele, then go in for ICSI. But if sperm DNA fragmentation was normal, then they would not recommend the varicocele ligation, and they would let the patient proceed for ICSI right away. Finally, there was a smaller group that said that if IVF fails, then they would ask the couple to come back, and then they would operate. So it's a split opinion, and the expert consensus was that it's a delicate decision. Sometimes you will delay the IVF ICSI unnecessarily by 6 months because of the surgery. So it should be individualized based on the couple age, duration of infertility, sperm DNA fragmentation, the rapport you have with the IVF center. And in fact, an interesting point was raised that if you have an elderly couple, you should not wait. You should proceed for ART. But because ART in the older couple has a low chance of success per cycle, you may also correct the varicocele simultaneously so that over the subsequent cycles, the chance of pregnancy may improve. So is there a role for medical management? We said that we don't have to rush into surgery. So we had a meta-analysis, this was presented at ASRM a few years ago, which looked at the effect of antioxidants in men with varicocele, some of whom had surgery and then had antioxidants, and some of whom did not have correction of the varicocele and just had antioxidants. And what we found that in both groups, the operated and the unoperated group, giving antioxidants improves sperm concentration and sperm motility and increase the pregnancy rates. When we look at the global survey, we find that about 1/4 of the respondents said that yes, before they go in for varicocele surgery, they would certainly give a trial with antioxidants. About 40%, the large blue channel, said that they would first do the varicocele ligation and then give antioxidants if there was no improvement. So the expert opinion is that in older couples, don't waste time, proceed for varicocele ligation, don't waste time with medical therapy, especially if they've already spent time and energy on treatment. But in the younger couple, especially with a short trying time, there could be a role for antioxidant therapy, maybe with a little bit of hormonal manipulation before you recommend varicocele surgery. Now, very briefly, so that we don't go over time, certain surgical considerations. There are many questions. We won't have time to review in detail all of them, so some of them I'll answer right away and take up only 2 or 3 of the issues. So which method is best to repair a varicocele? We recently had a debate in the Global Andrology Forum with one of the seniors pointing out a recent paper suggesting that in Germany, more patients were being treated by laparoscopy. Professor Colpi responded that in Italy, a large proportion are treated by embolization. The general consensus, however, is that the best method is a microsurgical subinguinal varicocelectomy, and that is preferred to even a laparoscopic approach, a non-microsurgical approach, or embolization. Should the gubernacular veins be tied? The general consensus was no. The posterior cremasteric vein is easily accessible and should be tied. The gubernacular vein only if it's a very large or a recurrent varicocele. The grade of varicocele seems to affect outcome, with several studies showing that larger the varicocele, greater is the likelihood of improvement. 2 or 3 controversial areas, and this is one which we are often asked that, okay, here is a patient with a large left-sided varicocele, grade 3, 4, but on the right side it's borderline, subclinical, maybe grade 1, not sure. Should you operate only the left clinical varicocele, or should you operate both the left clinical and the right subclinical? In the global survey, the majority said that they would go with the instruction that operate only the clinical side and operate the right side only if it was clinically obvious and not if it was subclinical. The guidelines from AUA again recommend operating the clinical varicocele. But if you go into literature, there's not much of literature, but the literature seems to suggest, particularly the large RCT from Sun, the second reference which I've given, that showed that if there's a left clinical varicocele, right subclinical varicocele, then there was a greater improvement when both sides were operated as compared to when one side was operated. However, the expert opinion was that do not operate the right subclinical varicocele, operate the left, and operate the right only if it is clinically obvious. In my own experience, which differs from the expert consensus, I found that very often the right side, which seems subclinical, still has very large veins when I explore. So I personally tend to be more aggressive, operating both sides, but the greater consensus is towards operating only the clinical side. And finally, some last words on a very controversial area, and that is the role of varicocele ligation in non-obstructive azoospermia. Now, this is going to be tackled by the next speaker, Professor Kolpe, so he may show you the same graph, so I'm not going to spend much time on it. Again, as we said, there's a controversy between AU and EUA, but our expert opinion was that there is some evidence, still controversial, and the decision again has to be a mutual decision with the clinician and the patient, because if we do decide to operate the varicocele, it means one more surgery, more expense, loss of time, but perhaps it may benefit the patient. An important opinion from the experts was that if sperm does appear after correcting a varicocele and non-obstructive azoospermia, freeze those sperm, because many of these men may once again become azoospermic. Should a subclinical varicocele be operated? The guidelines clearly say you should not operate, but surprisingly, in our global survey, only 40% said we will not operate, and 60% said that we will operate either, always, or in some cases. So the expert opinion was that you should not operate a subclinical varicocele. Even if it's grade 1, you may consider surgery, but with a very guarded prognosis. But given the global practice, perhaps this is a subject that needs more research. Should you cryopreserve sperm before a varicocele? We'll go over that quickly, but the general expert opinion and our guideline from GAF was that only if counts are very, very low, or if it is a solitary testis, or there is very severe OAT with declining parameters where that patient may be heading towards azoospermia. The time to wait for a result, general consensus is 3 months at least, 6 to 9 months, and if that doesn't help, then the patient should proceed for further treatment. So to summarize some of the more important recommendations, the diagnosis primarily is clinical. Ultrasound is a supplementary investigation and not one to be done in every case. Varicocele repair has a good chance of improving semen parameters when we are looking at oligoasthenospermia altogether, relatively less useful in isolated sperm defects. In younger couples, we need not rush into surgery. Antioxidants may help them. In older couples, certainly we should consider surgery. Operating subclinical varicocele is not yet recommended. Unilateral or bilateral will depend on the clinical findings. Microsurgical is the best approach. There is a role in selected cases of non-obstructive azoospermia for varicocele ligation. So with this, I will stop the talk, and maybe if there are any doubts, we can take them up during the question answer session, and it is over to the next speaker.
Okay. Thank you, Dr. Shah. Our upcoming speaker is Dr. Giovanni Kolpe from Switzerland.
Okay. Do you see my slide? Yes. Okay.
Yes.
Thank you. Well, I wish to thank Professor German and Professor Agarwal for offering me the honor of presenting the GAF clinical guidelines on the management of NOA. I must say that I have been working in this field for more than 4 decades, and really I examined a number of thousands of non-obstructive azoospermia. What is non-obstructive azoospermia is very well known, okay? But I must say that non-obstructive azoospermia management is a field where there are very many controversial subtopics. And I must say also that it's really a problem for most andrologists. Every day, my experience offers patients with non-obstructive azoospermia who were managed with inaccuracy, inattention, without any respect of the guidelines, and in some cases with true malpractice. And this is I see, and I must say that these patients who have their right expectation then can see that their expectations were betrayed. So I preferred to avoid longer speeches, and I will try to present directly these guidelines, because there were at the end we obtained 49 statements. Just a moment. And the guidelines of the GAF really represent a sun ray in the darkness, because all the scientific guidelines present many black holes. Well, management of non-obstructive azoospermia demonstrates considerable worldwide controversy and marked variation in diagnosis and treatment approaches, emphasizing the crucial need for well-designed and standardized clinical practice guidelines. Therefore, GAF wanted to give a concrete answer to this need. The literature research was explained by Dr. Pescatori for current evidence related to the epidemiological, diagnostic, and therapeutic approaches for NOAA, and the GAF recommendation statements for clinical practice guidelines were formulated by a collaborative force of a large worldwide GAF panel of 48 experts, very high number compared to the panel of experts of the other scientific guidelines, by using repeated rounds of the Delphi method and survey to reach a consensus. The statements were then graded as per the Oxford Center for Evidence-Based Medicine grade classification system as either strong or weak. Recommendations that were rated as strong by at least 80% of the experts were graded as strong, while otherwise were graded as weak. This is the paper of the GAF with the clinical guidelines on the management of non-obstructive azoospermia, bridging the gap between controversy and consensus, which is presently in press. So, diagnosis of non-obstructive azoospermia, we will see the clinical recommendation. Before all, the NOAA prevalence. The majority of cases of azoospermia are non-obstructive and are due to primary testicular failure and breed strong. Semen analysis. Due to possible fluctuations, one semen specimen might be not enough to diagnose azoospermia, grade strong. To establish the diagnosis of azoospermia, at least 2 separate semen specimens should be examined after being centrifuged and pelleted, grade strong. At least 1 month interval is preferred between 2 semen examinations in an azoospermic man, but the physician's clinical judgment should be used to determine the duration between the 2 tests, depending on individual circumstances or history of any recent medical illness that may affect spermatogenesis. Grade weak. My personal experience. A second ejaculation a short time from 30 minutes to 2 hours after the first one may rarely result in few sperm in the sample, predicting a positive sperm retrieval by microtesting. Hormonal evaluation. The initial evaluation of the patient with suspected NOA should include serum total testosterone level, FSH and LH, as these hormones are the primary regulators for spermatogenesis. When the serum total testosterone level does not match the clinical symptoms, or if there is any condition that could dramatically alter the SHBG level, then the calculation of bioavailable testosterone after HBG-SA is recommended, grade strong. Hormonal evaluation. Serum estradiol should be measured in obese men, grade weak. Serum prolactin should be assayed if there is an associated decreased sexual desire or erectile dysfunction, grade weak. Genetic evaluation. Karyotype and Y chromosome microdeletions tests should be recommended for NOA patients, grade strong. CFTR gene mutation tests should be done only in cases of aplasia or congenital obstruction, so obstructive esospermia, or in regions with a high prevalence of carriers for CFTR mutation, grade strong. Currently, other genetic tests like full exome or genome screening are not recommended as a routine test, grade weak. My personal experience, however, in case of women, CFTR mutations, CFTR testing is recommended for the patient too. NOA with varicocele. The clinical significance of a NOA-associated varicocele is uncertain, grade strong. This is the algorithm for the evaluation and diagnosis of esospermia. You will find it in the paper which is now in press. Differentiation of NOA from NOA. In most cases, clinical and laboratory results are sufficient to diagnose NOA or OA, grade strong. Further details are available in these two papers, the differentiation between non-obstructive and obstructive esospermia then and now, which has been already published in the Asian Journal of Andrology, or in this chapter, differentiation between OA and NOA, in this book by where Zodi, Gul, Shah, and Agarwal are editors, Non-Obstructive Esospermia, a comprehensive guide to causes, diagnosis, and treatment, in press with Springer Nature publisher. Scrotal ultrasound is not required for merely measuring testicular volume to differentiate between OA and NOA. This can be done adequately with a simple Prada orchidometer, grade strong. Scrotal ultrasound has an important role in assessment of the spermatic cord and epididymis and in ruling out any testicular pathology or tumors, especially before performing invasive diagnostic or therapeutic procedure, grade strong. This you can see here a hypervascularization inside the testis image at ultrasound, and you can see that surgically this was a cancer. Transrectal ultrasonography and pelvic MRI are not routinely required to distinguish between OA and NOA, grade strong. Trans and the pelvic MRI can be helpful in selected patients when esospermia is associated with a low semen volume to confirm a diagnosis of vasoplasia or ejaculated duct obstruction, grade strong. Scrotal MRI usage to distinguish between OA and NOA has not yet been incorporated into routine clinical practice awaiting future determination, grade weak. Diagnostic testicular biopsy should not be performed as a standalone procedure in routine clinical practice, which is what I see regularly every month. Diagnostic testicular biopsy should always be combined with surgical sperm retrieval with preferably sperm cryopreservation, grade strong. Predictors of surgical sperm retrieval. There are no preoperative biochemical or clinical variables that definitely predict positive sperm retrieval at surgery in patients with NOA. However, close to normal testicular volume, a history of sperm in the ejaculate, and histopathology with hyperspermatogenesis predict higher chances of sperm retrieval. Grade strong. And now we can see the treatment of non-static azoospermia with our GAF clinical recommendations. This is the second figure with the treatment algorithm of NOA, again in the same paper. Medical management. Hormonal therapy is not recommended for routine use, but may be considered in selected patients after adequate counseling. Grade strong. Exogenous testosterone should not be used for hypogonadal men with NOA who are planning testicular sperm retrieval and interest in future fertility. Instead, SERMs, aromatase inhibitors, or HCG administration can be used to raise testosterone without compromising spermatogenesis. Grade strong. Personal experience. In the case the low testosterone level doesn't increase with the SERMs or HCG, serum 17 hydroxyprogesterone can be helpful as an indicator of intratesticular testosterone. Surgical management. Consider perform microtese as the preferred and most efficient procedure for sperm retrieval in men with NOA due to its overall higher sperm retrieval rate compared to other procedures such as TESA and conventional TESA. Grade strong. A comment. The most cited meta-analysis of Corona et al. In 2019 showed that both conventional TESA and microtese in NOA subjects result in sperm retrieval rates of up to 50%, with no differences in comparing them. These conclusions are very biased. First, the authors used data from case series with outcomes for conventional TESA and microtese alone. Second, the overall unfavorable prognosis cases represented up to 43% of microtese cases and only 7.5% of conventional TESA cases. Third, the microtese series and conventional TESA series were significantly different in histopathology. Reviewing statistics only of the controlled study included in the meta-analysis of Corona, the superiority of microtese versus conventional TESA in general NOA population with a sperm retrieval rates of 49 versus 35.8%, and specifically in Scots NOA population, that is those NOA with a certain only syndrome, which represent the higher percentage of the NOA, with a sperm retrieval rate of 36 versus 12.3%, resulting in distributed shown by Esteves et al. In 2020. TESA is no longer recommended routinely in men with NOA given the low success rate compared to with TESA. Grade weak. Less invasive procedures like as conventional TESA may be tried before microtese in selected cases with good testicular volume, normal FSH, and or known favorable testicular histological patterns. Grade weak. Personal experience. If TEFNA is performed with many needle passings, such as in compound mapping, damage to the parenchyma is guaranteed, as I verified in many cases during microtese. Those who still support the use of multiple TEFNA have evidently never had the opportunity to witness the subsequent microtese. Normal FSH and volume in case of true non-static azoospermia confirmed by testis histology are mainly related to spermatogenic arrest. In our experience, the sperm retrieval rate is 38%. It may be acceptable in some cases to perform conventional TESA as the first step of microtese. Grade weak. In bilateral symmetrical tests, following a negative microtese on one side, microtese can be attempted on the opposite side with a 10% chance of finding sperm, grade weak. Testicular biopsy during surgical sperm retrieval is useful to establish histological diagnosis and support counseling for future management and to rule out germ cell neoplasia in situ, grade strong. So histology should be always performed. Patients should be informed of the small chance that the testicular biopsy may contain spermatozoa despite negative surgical sperm retrieval, grade weak. Techniques to optimize surgical sperm retrieval. Hormonal therapy can be a definitive treatment for NOA men with hypogonadotrophic hypogonadism, grade strong. Hormonal therapy for hypogonadism with normal to elevated FSH and LH levels is still controversial. Further research is required to identify the best candidate and the ideal regimen, grade weak. FNA mapping prior to surgical sperm retrieval is not routinely recommended, grade weak. There is currently not enough evidence supporting the use of imaging techniques for identifying areas of spermatogenesis and to improve the success of sperm retrieval, grade weak. Repeat surgical sperm retrieval. The recommended duration between the two procedures is 6 months, grade strong. My personal experience. The first microthesis should start by exploring thoroughly a limited part of the parenchyma. In case of insufficient or negative recovery, adjacent area will be explored. If again negative, a more distant area should be explored. In the operative report, an accurate description of the areas explored is strongly recommended in view of possible reoperations if necessary. However, performing microthesis timed for on-site pickup has greatly reduced repeat microthesis rates. Special consideration in surgical sperm retrieval. The experience of the surgeon and the time spent by the embryologist can impact the success of sperm retrieval. This is extremely important. Grade strong. It is preferable for the laboratory team to be in proximity to the operating theater to facilitate continuous transfer and examination of the microthesis specimen. My personal experience, the biological expertise in handling the microfragments of parenchyma is crucial to achieve the best outcome. In addition to long and patient research, careful mechanical processing of testicular tissue by shredding, mincing, tubular squeezing, then swim up or density gradient centrifugation technique are required. Enzymatic digestion by collagenase usually results very helpful in increasing the retrieval sperm number. The sample should be subjected to meticulous scrutiny, as I just said, and examination by the embryologist for at least 60 minutes in an attempt to identify sperm, grade weak. Either fresh or preserved sperm can be used depending upon the expertise of the center and the embryologist, grade weak. High-volume microthesis centers may have higher sperm retrieval rates in all NOA patients. NOA with men with genetic abnormalities. The genetic status of a male has a significant impact on the success rate of surgical sperm retrieval, grade strong. Surgical sperm retrieval should not be attempted in men with complete AZFA or complete AZFB deletions. Sperm retrieval may be rarely successful in incomplete, aberrant, or non-classical AZFA and AZFB microdeletions, grade strong. There is a reasonable chance of finding sperm in men Y chromosome AZFC microdeletion, grade strong. Genetic counseling should discuss the chances of finding sperm, the certainty of transmission of an AZFC deletion to the male offspring, and the option for alternatives such as donor sperm and adoption, grade strong. In patients with Klinefelter syndrome, microthesis can be offered with a 20 to 60% chance of sperm retrieval, grade strong. In embryos formed from 47XXY men, pre-implantation genetic testing can be discussed with the couple although studies suggest that most of these embryos have no chromosomal abnormalities and hence PGT-A may be avoided. Grade weak. NOA with varicocele. As Professor Shah already said, the decision to perform varicocele repair in case of NOA is a shared decision between the physician and the couple after a detailed discussion of the risks and benefits. The decision may be guided by parameters such as testicular volume, FSH levels, testicular histology if available, female partner's age, and overall fertility status, grade strong. Varicocele repair for subclinical varicoceles is not recommended, grade strong. Evolving therapies for NOA. The use of stem cells or PRP to treat NOA is still experimental and is not recommended for routine clinical use, grade weak. Gene editing with CRISPR case 9 for treatment of NOA is currently pure experimental, grade weak. Conclusive remarks. The Canadian guidelines 10 years ago, they stated that the testicular sperm extraction procedure should be offered to all men with NOA, but should only be undertaken in a center with expertise in microthese and where an ICSI laboratory with expertise in handling these samples is available. 10 years later, these words are worthy of being set in stone because they express a truth still indisputable today. The NOA management is a mosaic of subtopics, each of which has been or still is the subject of controversy, may be not always impartial. This controversy have generated enormous confusion in clinical practice and left room for too many personal behaviors. These results were confirmed by extreme variety of responses provided by 336 specialists from 49 countries to the questionnaires used in the GAF surveys. In fact, on many subtopics of NOA management until now, the scientific guidelines were still generic or completely silent. Prospective randomized clinical trials on surgical procedure are extremely difficult in humans, and studies in the literature currently offer only low evidence conclusions. The words of Schlegel's in a slightly different context are noteworthy. Although better quality evidence is desired, it is unlikely that such evidence will be forthcoming in the next future. Therefore, the prudent clinician must apply the existent evidence in addressing the NOA meal. The current GAF guidelines establish simplified, high-standard strategies that can easily and seamlessly guide the practitioners in their daily clinical practice for management of NOA, fully respecting the principles of good clinical practice. Thank you for your attention.
Thank you, Dr. Kolpi, for your presentation. And our last presenter is Dr. Manaf Al-Hashemi.
Thank you very much for the organizing committee and Professor Ashok for the opportunity to present about the antioxidant treatment. And I'm sure that everybody in the here in the conference prescribing hundreds of prescriptions every year for the antioxidant use in male infertility, and for many causes we can find the studies showed increased prevalence of infertility, whether for male and female, and we need to take in account, as the study mentioned, that about 50% of couples belong to male factors. Now, look, for most of the studies, especially from US, European, and even WHO, showed there is significant decrease in the last few decades in sperm concentrations. This is one of the US studies showed there is about 52% decrease from 1973 into 2011, from 99 million per mil, the concentration down to 47 million per mil. And this is another European study, and it is from Austria. It showed that the last 18 years, there is significant decrease in sperm concentrations per ml. The WHO also in 2022 showed about 50 million of couples suffered from infertility across the globe, and there is significant reduction in fertility rate, especially in the sub-Saharan Africa, North African, and Western Asia, where the Middle East and also Turkey is part of this significant reduction in fertility. Parallel with that, all the statistics show there is a growth of supplement market. We can find there is an increase in the maybe because of an increase in fertility rate, but also because most of these antioxidants are available over the counter, and there is significant buying of these medications through online shopping, and also there is another important promoting factors, which is by companies through different packages. The cost of this antioxidant also is very significant. We found about in 2024 is $258 billion for different use of antioxidants in different pathologies. In male infertility, only it's about $2.1 billion in 2023 and expected to be even 3.3 in 2029. And this is a significant increase in the cost and the prescriptions. Sometimes we considered we don't have enough evidence, but at least we have a pathophysiology behind that use. Simply because the sperms are particularly susceptible to reactive oxygen species through the plasma membrane are full of polyunsaturated fatty acid with multiple double bonds, and this is where the reactive oxygen species usually bind to the sperms and result in some defect in the quality. Additionally, the cytoplasm rate of the antioxidant enzyme in the sperms are extremely low. We should know that the reactive oxygen species have a positive effect on the sperms in balance status, have very important effect on a chromosomal reactions and sperm capacitations effect of the sperms, and this is very essential and crucial for fertilizations and developments. But whenever the balance is defected and the reactive oxygen species will be more, then results in significant lipid peroxidations and a bad effect on the sperms. So whenever the balance have defected because of many sources of reactive oxygen species, whether it is inflammation or varicocele or exposure into exogenous sources like smoking, alcohol, and so on, then this will result in significant negative effect of oxidative stress, result in lipid peroxidation, DNA damage, protein oxidation, mitochondrial dysfunction, and eventual defected spermatozoa viability, spermatozoa motility, oocyte fertilization, embryo plantation, embryo quality, and blastocyte formations, blastocyst formations. So all of this pathophysiology may be pushing us to use the antioxidants. And the most commonly used is vitamin C, vitamin E, CoQ10, and zinc, selenium, L-carnitines, and others like folic acid and lycopenes. And most of the studies showed most of these different molecules of antioxidant, whether they are vitamins or they are trace element or they are amino acid derivative or they are carotenoids, have different effect on the sperms. Most of them they are using to improve the sperm motility. Maybe we have CoQ10 used for enhancing the sperm concentrations along with the folic acid and lycopenes. But most of the others mostly used to enhance the sperm quality. Now, if you look for the Global Andrology Forum, released many of studies led by Ashok Agarwal and colleagues, and they found that different antioxidants can work on different structures of sperms and result in different improvement of functions of sperms. And that's why maybe most of our use, we are using combinations of antioxidants. This is one of the studies showed most of the available brands of the antioxidants use different combinations, but the most common ingredients is coenzyme, this is CoQ10, L-carnitine, selenium, vitamins like C and E, and zinc. What about the evidence available? Now we found the large overview studies is about 90, including 90 randomized control studies with more than 10,000 participants with the interventions of more than 20 types of oral antioxidant, and there is comparison with a placebo or head-to-head antioxidant trials. And the outcome looking for live birth rate, clinical pregnancy, adverse effects, adverse events, and sperm parameters. And the summary showed that the antioxidant may increase slightly the live birth rate, and the certainty of the evidence is very low. It's the clinical pregnancy rate also may be improved by antioxidant, but the certainty of evidence is low. It can increase the adverse effect like miscarriages and gastrointestinal discomfort, but with very low incidence. What about the effect on sperm parameters? There is some improvement, but the data are insufficient and inconsistent across the trials. So this study concludes that there is very low, too low certainty. Either it is very low or sometimes low certainty in some studies of evidence supporting the use of antioxidants to improve the live birth and pregnancy. And there was the evidence is inconclusive, and we have a call to better design, large-scale randomized control trials should be done. This is another important studies from our group. Also, it goes with the same directions, but we found, at least in the pregnancy rate, there are some of the studies are in favor of use of antioxidants. And we can find other outcomes also, like live birth rate and sperm concentrations, improving the motility and sperm morphology, sperm DNA fragmentations. But we found the evidences here, either it is very low, but some cases we have moderate evidences. And if we look for the individual antioxidants, we found the carnitine. It can enhance the sperm motility in some of the studies, in addition to sperm morphology, while the omega-3 can enhance the sperm concentrations, and the zinc can enhance the pregnancy rate. So sometimes the studies are in favor of individual antioxidant, while this is another study showed that the CoQ10 is very important for sperm concentrations, while the carnitine is the best for sperm motility. And the conclusions of this study, that combination of CoQ10 and carnitine can better to enhance different subfertility of men. The GAF, as all of my colleagues mentioned, that we depend on the global survey. And this is one of the largest global survey done by Global Andrology Forum. And we got about 1,300 responses from 88 countries. And we found that 85 or more than 85 of respondents, they are using the antioxidants for most of the patients with the male infertility. And the most commonly clinical conditions are risk factors for oxidative stress like obesity, smoking, idiopathic oligoasthenospermia, unexplained infertility, or even individual use of individual sperm deformity. While the durations most commonly they are using for 3 to 6 months, but we found about 10% of the respondents, they are using even more than 6 months, and 7% of them, they are using indefinitely until to achieving the conceptions. And this is makes sometimes alarm that we are abusing the antioxidants, because whatever the use of antioxidant, it's helpful, but there are some harm definitely of overuse of the antioxidants. From this Global Andrology Forum, we found that the most commonly used is zinc, vitamin E, L-carnitine, coenzyme CoQ10, vitamin C, selenium, and folic acid. And most of the respondents, they are using for more than 25% of their patients and up to 75% of their patients. The evaluation of respondents to the evidence, why they are using and utilizing antioxidants, most of them, they say we have scientific evidence. And some of them, mostly depends on personal experience. Why they are not using sometimes, or reason not to recommend, they say mostly because there is no enough scientific evidence, or they are unfamiliar with the field. So when we ask them what are the limitation of use, why you are not using antioxidant, they are describing the cost and the long-term therapy and low treatment adherence as the main causes. And then they mention about efficacy. It looks like they have belief of antioxidant effect on the male infertility parameters based on personal experience. And most of the necessity of clinical practice guidelines, most of them, they say we should have guidelines helpful, and we are much needed to have clear guidelines on the topic of antioxidants. Why we have mentioned that sometimes the antioxidant abuse, it's harmful. Definitely this is also mentioned by our one of our colleagues in GAF is Dr. Ralph, and they mentioned and Dr. Ashok, and they say that this is what is called antioxidant paradox. Whenever the antioxidants concentrations will be more, it can have also negative effect on fertility in some of cases. Additionally, they mentioned that many of the studies, when they are using antioxidants, there is no significant change in the outcomes, whether related to the live birth or in sperm parameters. Now, the GAF, especially the preparation of the guidelines, we are separating the studies into low quality and high quality. And this is have very important different conclusions. Whenever they say there is improvement in reporting after antioxidant, the low quality, they say the improvement up to 85%, but the high quality studies found to be only 65%. So it's very crucial to look for the best quality. And also, this is one of the studies by GAF, led by Dr. Ashok Agarwal. We found that the most of recommendations, as in this diagram, that we need to look for the cause of the male infertility rather than to give empiric antioxidants. We need to look for measurement of oxidative stress by using some of the techniques like myoxis, and to measure the oxidative stress. And then if we found it high, then we need to look for the cause. If it is varicocele, we need to treat by varicocelectomy. If it is related to inflammations like prostatitis, we need to have anti-inflammatory and antibiotics. And also, we don't forget to enhance always and encourage lifestyle changes, stop smoking, reduce obesity, healthy exercises, and healthy diet. And only if there is unexplained or there is idiopathic, then antioxidant supplementation will be the best. But we need to monitor reactive oxygen species after the treatment in order to determine the exact doses and duration of treatment. Well, this is one of the very important, maybe model studies I want to show you about the use of CoQ10 in improvement of sperm fertility. And it is like experimental. Nicely, they have infertility people and in one arm and the normal fertile in the other arm. They measured the total antioxidant capacity in the sperm serum and the seminal reactive oxygen species measurement, and they measure even the QQ10 and the seminal plasma, and then they give them the QQ10 courses, and after that they measure, after 3 months they measure the same parameters in the same patient and to see the improvement. Whenever these measurements become available in our everyday clinical practice, then definitely our treatment with the antioxidants become more specific. Now, Professor Ashok and Gav also in this study look about the best or the highly cited article for antioxidant, the most 100 studies, and the conclusion was found that there is inconsistency. There is a significant variability in reproductive outcome. The redox balance is unclear about the exact cutoff value is still unknown. The antioxidant optimization is needed. Should have ideal antioxidant composition and concentration to maintain redox balance. And also we need to look for the more mechanisms of this antioxidant, and we look for the heterogeneity in the treatment, whether there is single or combined or combination of the antioxidants. So all of these, when we considered in GAF, and we look for the underdeveloped recommendations from other societies. It looks like for European Academy of Andrology mention about antioxidant, there is, according to the current evidence, we cannot recommend with or against antioxidants, while the American Urology Association mentioned that the clinician should counsel the patient about the benefit because the benefits are often questionable. And the current data suggests they are likely not harmful, but also the benefits are questionable. Look for the Italian Society of Andrology and Sexual Medicine. They recommend against treatment of antioxidants empirically, and only if there is idiopathic infertility, or if there is clear evidence that there is high reactive oxygen species. And the European Association of Urology, there is no clear recommendations. That's why, based on all whatever I show you now in the slides and overview, we considered some of the recommendations on the available evidence, and I'm sure that this will develop our practice, because the recommendations now, we don't depend on the empiric treatment. We need to look for identifying the specific causes of infertility to deliver the target therapy. And whenever we found what is called before unexplained or idiopathic male infertility, we need to look for the oxidative stress and sperm DNA fragmentation, because there is significant number of them. We found high oxidative stress and sperm DNA fragmentation, and we need to treat the cause. Also, the important statement that we need to assess the oxidative stress using standardized method. This will identify the appropriate candidate for the antioxidant treatment, and then regular monitoring of these oxidative and reductive stress after the treatment is very helpful to know and to know exactly the course and the response. And we need to also, some cases, whenever there is like a chronic genital tract infection treated by antibiotics, varicocele treated by varicocelectomy, we can add also antioxidant treatment as a co-treatment with this definite treatment modality. And also, whenever there is idiopathic oligosteinoteratospermia or unexplained male infertility, we found that empiric then antioxidant therapy can be of use. The other important things that shall we use single or combinations, and the recommendations is that balance antioxidant formulations combining lipid antioxidant like CoQ10 with water-soluble one like L-carnitine will be more effective to maintain redox hemostasis. And the treatment protocol is the best 3 to 6 months. And this is very important. And whenever we need to prolong the courses after 6 months only if there is evidence that still we have high reactive oxygen species concentrations or there is antioxidant capacity less than normal. Only in these cases we can expand the courses, otherwise the maximum will be 6 months. The use of antioxidants have a significant improvement on different sperm parameters, on concentration, motility, morphology, and of course, sperm DNA fragmentation, as mentioned by our colleague. Also, there is definite need for larger randomized control trials that mention how the antioxidant lead to improvement in the outcome, both natural and artificial induced pregnancy, because there is significant studies showed the courses of antioxidant could enhance the outcome of IRT. In addition, we are missing in practice for advise the patient for lifestyle changes and the best healthy diet, that it is the main source of antioxidant, and of course to stop smoking and weight loss, and this is one of the important recommendations from GAF also. And the oral antioxidant, whether it is for combination of sperm abnormalities or even helpful in isolated cases of acinospermia or teratospermia. The patients, whenever found that there is leukocytospermia when treated with antibiotics, we found that the addition of oral antioxidants is helpful for better and faster recovery. Also, we found that the very limited role in antioxidants for treatment of NOA, and the oral antioxidant is very helpful in cases even with isolated high sperm DNA fragmentations. So with all these 18 statements, we got it from more than 198 experts from all over the world. I think we can at least have more guidelines in our clinical practice and justify our prescriptions, because the antioxidant treatment is widely used, as I said, but it is a lot of improvement and developments required to know the best mechanism, the best combination, and the best courses. And of course, the GAF guidelines can help with these statements and future improvement also. At the end, thank you very much for your attendance.
Okay. Thank you, Dr. Al-Hashemi. We have a little time left, so we won't be able to take questions from the floor. I want to thank all speakers for their great presentations. Always, I'm happy to work with you in GAF. So I want to introduce Dr. Rupin for closing remarks. Thank you.
So a big thank you to all the speakers and to Professor Ayman and the Society for inviting GAF to share the work that we do. We put in a lot of effort, and it's always a pleasure to have the opportunity to share it with colleagues so that the academic work we put in gets spread widely. So now very briefly, the last 3-4 minutes, a few take-home messages that you could carry home. So the very first talk, which was on sperm DNA fragmentation, key messages are that there are various techniques available, tunnel SCSA being the commonest, but probably, practically speaking, you will use what you have available. In terms of who should be treated, we recommended that men with idiopathic male infertility where there's no cause evident, those couples who have recurrent pregnancy loss, and those men who have the risk factors for elevated SDF. So not everyone needs to be tested. Those were guidelines from the AUA also, but those who have these risk factors should be tested. And the treatment encompasses a range of therapies. We have to start with lifestyle change, weight loss, stopping smoking, proper diet, move on to add the antioxidants, correct any correctable factors, and then if there's no improvement, look at a surgical option like varicocele ligation, if it is present, and if it's still elevated, then we have the option of lab manipulation, which is the use of microfluidics or the use of testicular sperm. Coming to varicocele, we saw there's a lot of controversy. We started by saying that the primary diagnosis should be clinical. Not all men need routine ultrasound to look for a varicocele, especially if their clinical examination is normal, but ultrasound has a useful supplementary role. Varicocele ligation is best done, varicocele repair is best done microsurgically, subinguinally, but perhaps one should stick to the technique one is most comfortable with. One has a good chance of benefiting sperm count, motility, morphology together. However, the impact on pregnancy rates and live birth rates is still disputed, though it seems that there should be some benefit. We spoke of varicocele ligation, unilateral or bilateral, and general recommendation is operate only the clinical varicoceles. In non-obstructive azoospermia, the use of varicocele ligation must be individualized. Coming to the talk on non-obstructive azoospermia, we had a lot of recommendations. We have to make sure that the semen analysis is done correctly, more than one sample, appropriate interval, and a useful hint that sometimes two semen samples, just a couple of hours apart, may help find sperm where no sperm was seen in the first sample. The diagnosis will require a routine hormone profile, FSH, total testosterone, free testosterone being done only in selected cases, prolactin, only when there's erectile dysfunction or low testosterone, estradiol in obese patients. Genetic testing is useful and important. The relation between varicocele and azoospermia is still unclear, needs to be individualized. Important point was that ultrasound should not be used just to measure testicular volume. That's a clinical measurement. However, ultrasound is useful to identify any other intratesticular pathology before a surgical exploration. Many urologists routinely do a transrectal ultrasound. That is not recommended unless volume is low and there's azoospermia with absence of fructose. Diagnostic biopsy, which was the mainstay in the past, is generally not performed. If a biopsy is done, it should be a therapeutic biopsy with one biopsy going for diagnosis. It has a very limited role, except in cases of hypogonadotropic hypogonadism. Finally, coming to the role of antioxidants, reactive oxygen species plays a very important role in a large number of so-called unexplained idiopathic infertility. And there, the use of antioxidants may help, but the evidence till now is quite limited. However, empirically, most of us wind up using antioxidants. The suggestion is that a combination of antioxidants, which are both water-soluble and lipid-soluble, may perhaps give a better result. A combination involving zinc, vitamin E, carnitine, coenzyme Q10, and others seems to be preferred. There could be a role for monitoring the level of oxidative stress to guide therapy, but that's often not available or very expensive. Antioxidants may be given for 3 to 6 months, but one should avoid an overdose, which is sometimes a temptation, because like oxidative stress, there could be reductive stress, which should then have a negative effect. So with this, I think exactly on the dot, we are going to end this meeting with a big thank you to the audience, to the Turkish Society, and to all the speakers.
Okay. Thank you, Dr. Alpin. Dr. Agarwal, do you want to say anything? I'm closing the session.
No, I think the program has gone really well. I want to thank the Turkish Society of Urology. I want to thank the Andrology Working Group, Dr. Arman Sihan, for inviting us. I want to thank my senior colleagues, Dr. Eduardo Pescatori, Dr. Rupin Shah, Dr. Giovanni Colpi, and Dr. Manaf Al-Hashimi for excellent presentation about the new guidelines developed by the Global Andrology Forum. Thank you very much for the opportunity.
Thank you.
Thank you. Bye-bye.